Okay, and something a little bit different today. I've got with me a palliative care doctor, and we're going to be talking a little bit about DNA CPR from both a clinician point of view and patients. Mark, would you like to introduce yourself, please?
Hi, Sophie. Thanks for having me on the program. I'll call it program. My name is Mark Taubert. I'm a palliative care consultant. I work in Cardiff, and I'm clinical director at a cancer center, Lindra Cancer Center. I also have a university role. Plus, I am lead clinician in Wales for all things advanced care planning and DNA CPR as well. So I guess that's kind of the direction that the topic today that we're discussing will be going in, I think.
Yes, so you're
Unless you've got
certainly,
something different planned for me, Sophie.
yeah, so you've certainly got plenty of expertise when we're thinking about DNA CPR. And just mention a little bit about your talk CPR as well. And there's lots of things on YouTube people can already
Yes.
find.
Yeah. I mean, I don't think I went into medical school or came out of medical thinking I'd be sort of a lead person for DNA CPR one day. But then, and I think we'll probably talk about this during the program, you have experiences during your career as a doctor or healthcare professional, and maybe also as a relative that you see these things and you kind of think there's something not quite right here. And so it's always been a topic that I think I found interesting, including the misconceptions that surround this topic area. And so a few years ago, I pitched something to one of the hospital trusts I work with, saying, look, why don't we create some videos where we explain CPR, its success rate, but also do not attempt CPR, and why on earth one would want perhaps a forum and a conversation about this topic. And they all said, no, let's not go down that route. It's a very controversial topic. We don't want to distress people. We want to focus on the positives. And I said, well, I don't think it's necessarily a healthcare professional's job to just focus on the positives. Sometimes we need to bring across difficult news and challenging things as well. We're not selling cars here. We're not trying to sort of say how well the emissions are doing and flogging something. We need to sort of sometimes also bring the more challenging aspects across. And of course, some people will probably find that difficult. Other people will find that absolutely fine. So we created some videos eventually. I kept it under the radar a little bit, but actually sat with the patient group in our trust, and they said, yes, of course, how patronizing that this hasn't gone through already. We're really interested in this, and we do need to talk more about death and dying and even making wills and things like that. But the CPR is a really important aspect of it. Please, and we want to be involved. So I had patient involvement, which was really great. And they even scripted the videos and how they should be run. And then we got a local company to do the videos in quite high quality, filmed some of us, some healthcare professionals, some patients, and others talking about this topic. And I'd say now we've got about 8 or 9 videos on DNA CPR. We've got about 8 videos on advanced care planning. So one's talkcpr.wales and talkcpr.com and talkcpr.cymru if you want to see them in Welsh. And the others are on advancedcareplan.org.uk. You can see a number of videos there as well.
Brilliant. I think their initial response about it's too negative and people were too upset is exactly why we need a lot more material to share and we need to open up this conversation because that's the whole point, isn't it? People want to deny it, pretend it doesn't happen, hide it
Yeah,
away. Let's not even say the word death because it's too upsetting. Whereas actually what we want to do is completely, really probably transform the way we think about it. Well,
agreed.
certainly, and I like the fact that I've heard you discuss before about ordinary dying. Um,
Yeah.
you know, and that's I think what people need to kind of think about and differentiate and understand a little bit more. And
Yeah.
probably clinicians could be better a lot of the time at discussing it with patients because it often is felt to be a very tricky conversation.
Yeah, I mean, I think so, and I think you said it can be quite a typical response. I agree, but it's also a response, and there are different responses to this. And often when I talk to patients and families about this, and I sort of feel my way forward a little bit in the conversation, because I am aware that some people do not want to talk about death, dying, etc., etc. And I give them the chance to put roadblocks in the way for me to stop the conversation. So I said, are you okay to continue this conversation? I'm happy to stop this conversation now if you find it distressing. Most people will say, no, please continue. We need to discuss this. Others don't. But there are many people who say, well, why hasn't someone actually discussed this with me beforehand? I'm completely fine talking about these things, and I think sometimes perhaps doctors, nurses, managers, healthcare professionals might be overly patronizing in terms of wanting to protect the person. You're sort of focusing on all the good treatments that you're giving, and the cardiology drugs, the chemo drugs, the radiotherapy, etc., etc. And let's focus on that, and let's not be doom and gloom. But actually, people are. I think when you talk to them as grown-ups intelligently, and they get it. They really do get it. I think it's nearly patronizing to think otherwise, actually. So that's
Yeah.
kind of how I approach it.
Yeah. So what do you think are the most common challenges that healthcare professionals do face when thinking about having these discussions?
So I think, I mean, I have a lot of these conversations with patients and family members, sort of, I'd say on a weekly basis. I think the first one is that your blood pressure goes up in the first moments before you talk about it. I can't help it. It's still like that for me. So I'm still a bit worried at the reaction that I might get because I've had very varied reactions. And most of the time I don't need to worry so much because actually it's absolutely fine. But yeah, I do try to sort of calmly go into the topic, and I think that's the best way forward. I guess other doctors maybe who haven't had so much training, or other clinicians who feel a bit less well trained on the topic might let their blood pressure take over a bit and get quite tense about it, and then say, "Oh, you wouldn't want us to jump around on your chest, would you?" And that sort of quick, hurried, I want to get it out of the way narrative never helps in those situations, because then the patient kind of thinks, well, I didn't understand what the hell that person was talking about, and B, I've come to hospital for treatments. I want people to save me if there's that something is going on, and I'd want that as well. If I go into hospital and someone talks about jumping around on my chest, A, that's not particularly comprehensible, and B, it's not a conversation. So you need to sort of have it like a completely normal conversation. You need to chill out about it. You need to give the patient an opt-out if they don't want to talk about that sort of topic. You need to take it slowly and in a relaxed way and talk like grown-ups, bring across all the different issues that CPR has. CPR is wonderful for Fabrice Muamba and footballers who collapse on the pitch, but it is in itself quite a selective if some people say, people are ageist, or people are, disableist, or whatever, basically. No, it's actually CPR in itself. If you look at different statistics, meta-analyses in its success rates, well, people with metastatic cancer, their success rate of having CPR and then leaving hospital in some shape or form alive is about sort of 1.9%. And what does that alive mean? Is that, with part of the, brain being completely hypoxic and not working anymore, and other things. So it's really getting all those different things across of, this is one intervention we're talking about, not just withdrawing all your care or anything like that. This is one intervention which is particularly unsuccessful, and bringing that across. And I think the other challenge, you're going to have to stop me, Sophie, if I'm talking too much. I think the other challenge is sometimes we dress this as, oh, I want you, the relative, to make the decision. And I think that's really unfair as well. I think sometimes we need to own this, and we need to own up and sort of say, I think, or we, the clinical team, feel that CPR wouldn't work in this situation. That CPR would be a dreadful intervention that starts at the point of death, and then you're trying to roll back. And it's very traumatic for everyone involved who witnesses it, including relatives and others. I think we need to own this more and sort of say, I don't think it would work. I think it would be very bad. My recommendation would be not to opt for CPR, but you can have everything else that comes beforehand: IV antibiotics, blood transfusions, admissions to hospital, chemotherapy, immunotherapy. I mean, I have patients who, have had nearly insisted on DNA CPR forms. I've had them in their shirt pocket for several years, and I've had sort of experimental immunotherapies, in leading cancer centers. So it's that wanting to break the cycle of some people might misinterpret DNA CPR as meaning do not treat, and I
Yeah,
think we've gone beyond that. I think that's just not the case anymore.
yeah. I think the media hasn't helped us, both in
Mm.
the form of TV shows and movies where somebody
Hmm.
collapses and then somebody just pats on their chest gently and then they cough and splutter and come round. And that's
Yeah.
what we think. And also, there's been so much negative publicity. Was it called the Liverpool Care Pathway that we used to use?
Yes.
And there was
Yeah.
a whole thing about, doctors are killing patients. So I think that really left a huge stain on what patients understand DNA CPR to be.
Yeah.
It was wanting to get rid of them. I mean,
Yeah. I mean, you could argue, in some ways, you could argue there is no such thing as negative publicity. Um, but you're quite right. The sort of the way that CPR is portrayed, that you have CPR, there's a heroic male doctor and a heroic female nurse, usually that sort of trope. You just do a few chest compressions, a few shocks, they rub together the
yeah, yeah.
electric. Yeah, that's a classic as well. They give the shocks, and the patient walks out of hospital 2 hours later saying, "Yeah, really good care." Is that hasn't helped in many ways. Equally, I think the media narrative, which went a bit crazy, I think during COVID as well. I've just, I've come out of conversations with bereaved families for justice, for Cymru, who are looking into DNA CPR, and I've had a really interesting discussion for them. I nearly wonder whether we need to sort of hook into the media narrative, even the negative media narrative, a little bit, and actually take advantage of it a bit, because everyone's talking about DNA
Yeah.
CPR. I think it's far more in people's mindsets now. I don't know about you, Sophie, but people are talking to me about it in consultations a lot more. And that gives me the opportunity to say, okay, let's actually talk about this, because it's a useful topic to talk about. I can maybe clear up some of the misconceptions, and you can come across and give me your views on it. And then it becomes a conversation, which is never a bad thing, I think.
Yeah. What I tend to find is that the patients themselves are happy with that decision and want
Hmm.
that to be made, but it's the families who struggle, who say, "No, I want you
Yeah,
to do everything you can to save my mum or whatever." And you're
yeah,
like, "Well," and then it's about the understanding. And I think as a GP, the
yeah,
real challenge we have is the time
yeah,
because
yeah, that's
a
true.
10-minute consultation, um,
Yeah,
which is why in the end I actually made the YouTube video about TNCPR decisions because
yeah,
I find that often I would have the discussion with a patient, they would be happy, I would create the DNA CPR, we'd talk about, it would all go well,
yeah,
but probably a lot longer than 10 minutes anyway. And then
yeah,
the patient's family would speak to the patient and they'd be unhappy and they'd want another appointment to discuss it again.
yeah,
So I was kind of thinking, hopefully this video can help communicate so much of what I want to say that I don't always have time to say. They can share it with
yeah,
their family, watch it a couple of times, have a think about it. So that's why
absolutely.
we're just so time poor in GP.
Yeah. Absolutely. I mean, I do get that a fair bit as well. I mean, my heart often sinks a bit, because what I try and do is I have a conversation with the patient, and some patients will say, "Oh, don't talk to my wife about it. It'll just distress her." And I do
Mm.
try and sort of say, "No, please, let's get her involved, because ultimately, if you take this form home with you, then she'll find it out that way, And then people usually say, "Yes, okay, please get my wife involved." I had two this week where they said, "Oh, my family kind of already know," but I wasn't so sure whether that was the case or not, and I kind of just wanted to dig a bit further. And then with one person, the family wasn't actually as informed as the patient thought they were. Um, but yeah, so that's a really tricky one, because you need the family and the loved ones and the significant others very much involved. It's a wider decision than just the individual, because of course, if they're at home and the paramedic and they've called 999 and the paramedics come to the house, there's no good if
Yeah.
only one person knows and that person can't speak at the moment.
No, exactly. So how do you think clinicians could kind of better prepare for these discussions?
I think I think practicing, watching others do it. I think regular training on it will be useful. That's what we certainly try and do here. I've recorded a few videos. we even recorded, and really grateful to Kat, my patient who allowed this live kind of recording of an outpatient consultation on DNA CPR. We even recorded an actual DNA CPR conversation in a clinic that I had. It's on the Talk CPR website if people want to watch it. And we broached the different topics within DNA CPR, and she's quite clear on what she'd want considered or not. She's quite a young patient. She's in her 30s, and the different aspects that she thinks are important. But watching others do it a little bit, sometimes you pick up tips, or sometimes you pick up things that you say, "Oh, I wouldn't want to do it like Mark did it just now. I would do it in a different way." Bringing that across in the right way, I think that's the tricky bit. Where I struggle is how brutal I should be in terms of my experiences, and perhaps your experiences as well, when we have actually given CPR. And I'm going to give a little trigger warning here in case people watch this and don't want to listen to the next bit, because I'm going to be fairly graphic. But you will remember, Sophie, in your years when you were, on the wards and were called to an arrest call. And I certainly remember this as well in my house days in Birmingham. You would be called to an arrest call, and you would by default give CPR. The whole team would start the CPR. I would often, give the chest compressions, and you would hear the loud crack of the breastbone under your hands. You would hear the crack of the ribs. You would be causing internal bleeding. Suddenly the room fills with smell because the individual underneath you has lost their bowel motions through the brutality of everything. People are sticking needles in. You're being watched by relatives who think, "What the hell is going on here? How can this be?" And most of the time it was unsuccessful. I remember the ones that were successful in my entire house year. I remember the occasions when it was successful, and of course, when it was successful and the patient gained some sort of consciousness after that, you remember it especially. But I also remember the ones where it was successful and they lived for another maybe 2 months, sometimes 2 weeks or so, needing total care, and their brain cell, a lot of their brain had gone basically due to lack of oxygenation during the procedure. And so how do we convey that? How, in an unpatronizing way, how do we tell people that is CPR? CPR starts at the point of death, and now you're trying to roll it back. It's not about whether you give someone fluid resuscitation. It's not if you give someone red blood cells or something like that to top them up. This is not it. This is CPR. This is a highly, highly, highly interventional procedure. Leaves no dignity. You have to rip up someone's shirt, rip off their bra, give electric shocks. How do you sort of convey the brutality of it without being accused of being some sort of Quentin Tarantino of the medical world, of being so
It's also
graphic?
traumatic for the staff involved, isn't it? I remember my first as a FY1, and I had done all the training and I felt quite confident. I knew exactly what to do. And then the moment I put my hands on the chest and the cracking of the ribs, no one had told me that. No one had said that's what was going to happen. And I felt sick to my stomach, and and it wasn't successful. And I was really upset with them. And I feel actually we also need probably better training in managing how upsetting it is actually as clinicians. And again, it's definitely not like to be.
And I think that's so important. And you described the feeling of sickness, and I had that as well. And a colleague of mine in America described it very vividly, how she vomited after her first CPR session, which was prolonged and really brutal. And I guess that's something somehow we need to get that across. But also, what's the
prepare the clinician for it, because I don't think I was prepared. I knew what to do, and I knew but I knew how many inches down I needed to be pushing and how to feed, but no one had prepared me for the brutality of it.
Yeah, it's not like with the doll, is it? It's
No, exactly.
the recent doll. But the other thing is also to portray the alternative, because often in the hospice setting or in the cancer center setting, when you're clear that is not something that will be done, and the person is in the last moments of life, and you can kind of support them, there is still a lot of care we give. I mean, the paramedics here in Wales get trained to give really good end-of-life care. So if they get called and it's clearly a situation where CPR isn't appropriate, there's still lots they can do in the last moments of life, maybe support with some oxygen or give some medications to help with the breathing, get into a more comfortable position. They're often trained in knowing what positions are best to aid breathing and things like that. There's so much dignified stuff we can do to make it a better experience. We all die at some point, that's a given. But do we all need to die with this absolutely ferocious intervention? I think that's where we have gone too far in medicine. And I think that's where we need better, earlier discussion. Not a call for ban of DNA CPR forms like the Daily Mail or whatever, but better DNA CPR conversations, end-of-life conversations, and like my good friend and colleague Julian Abel often says, Mark, you're obsessed with DNA CPR. We need better what matters most at the end-of-life conversation in general. We need to sort of find out from people individually, if you're in the last moments of your life, where would you want to be? What settings would you want to be in? What carers would you want around you? Have you got any preferences there? And it's amazing what people come up with. They say, oh, there's certain things I don't particularly like. I wouldn't want a male carer, for instance, and things like that. And then you sort of find a list of things that are really important, and you can then maybe also tackle the things that are important to healthcare professionals or that you sometimes prompt with, but continence care and all sorts of things that are really important. It's a whole package of things that we need to discuss, and CPR is just one of them, but it's a pretty important one. And it looms largely in your brain and my brain because we've given it so many times and so often unsuccessfully. But we need to get it over and across better, don't we, in terms of what it actually involves.
I mentioned in my video that women and families are all encouraged to write a birth plan. But nobody writes a death plan because that sounds macabre and strange. But actually, it's a good idea. And that's, again, what we can be more open about. I feel like maybe I should do on really advanced care planning as well, really, to kind of get people to think about what they may or may not want at the end of life and talk to their families about it and to have a plan. And then I think it's because the most frightening thing when I've dealt with people who are dying is a fear of lack of control and the unknown. And I think if you can help them, because a lot of the time, because that's what people say to me, and the thing I'm most worried about is what's going to be like. I genuinely can reassure them that usually you will just be asleep and your hearing will think the last of those family can talk to you, and then hopefully they'll turn it off. And then that's the thing. But I think so those are things that we also need to have the better education.
Yeah, 100%.
That's 10-minute consultation.
Yeah, exactly. And that's so important. I mean, and then the more you become involved in this area, the more you sort of see areas that need addressing more as well, and kind of the different things that you can do to improve end of life care conversations. For instance, when you're writing documents, and we have an all Wales DNA CPR policy, for instance, we've got advanced care planning policies and guides and various things like that. But being so careful that you manage to get in all different groups and no one feels excluded. So, for instance, when you have same-sex couples and they may be in a civil partnership, or they may be married, or they might not be married, but they are the significant other. They are the person who cares for the other person, and making very sure that your forms and your policy reflect that it might be someone's partner who is the main spokesperson then, and who speaks for them. I mean, of course, lasting power of attorney for health and welfare becomes really important in those situations, and I would encourage everyone to go to the Office of the Public Guardian and sort of register one of those. It can take up to 3 or 4 months sometimes to do it properly. So, but in reality, lots of people don't do that. In reality, I think, what's the statistics? Only 10% of people have even got a will, so we kind of, we are really failing with that narrative in some ways, and need to get people talk about it more openly. But yeah, it's just encompassing all those different aspects, making sure that people are treated with respect, that significant others are seen with respect and who they are and can be the spokes people for those individuals, respecting the Mental Capacity Act, doing good best interests decision making for individuals who might have lost the ability to communicate themselves about what they would want, and then finding out what they ideally would have wanted from their nearest and dearest, really. Sometimes, unfortunately, it's not the dearest, and you find it's the nearest, but not always the dearest. So you have to be careful with that expression as well. They don't always get on, but that's families and friends and neighbors for you. I suppose that's all the things we see, really.
Yeah, yeah. Okay, and how do you think clinicians can be supporting families after the decision's been made? Is there anything that clinicians should be thinking about and focusing on?
Yeah, I think I mean I've worked in the community, I've worked in hospital settings. It's unfortunately the continuity factor is always a good one, but if you can't always offer the continuity factor, then good palliative care, CNS support can be useful sometimes. Making sure that if you as a GP or me as the hospital consultant have had a full DNA CPR consultation with the patient and the family, that is recorded somewhere, that's recorded properly. Unfortunately, in some ways, across a lot of parts of the UK, including Wales, we still rely on paper forms to communicate that with our colleagues, what discussions have been held. We need to get to a better sort of electronic central patient record that shares that information, and then everyone can see, Mark, on the 14th of April, had a full discussion with the patient and with the family as well. This is what they concluded. Of course, I can then say, I can see you've had a discussion with Mark Taubert on that date. Is there any further questions you've got? Gives you immediately a way into that conversation, and then you can get clarity on that. If you don't know that and you have to start the whole conversation again, they might go, oh, yet another doctor who has to obsess about this topic, basically. And it can then seem clunky and discombobulated, or however you say it. You know.
Yeah, yeah. Yeah, and then they get annoyed that we're not reading their notes.
Yeah,
But
exactly.
yeah, so I did an audit actually just last month or the month before about our DNA
Hmm.
CPRs in our surgery, and make sure that it's a high profile reminder on the homepage, so that's for everyone to see, paramedics,
Hmm.
everyone, that it's on the problem list and that it's reviewed at least annually.
Hmm.
And we have regular palliative care meetings, so most people are on the palliative care list, but not
Yeah.
all. But so I think that's something that practices, certainly GP practices, need to make sure they're checking up on
Yeah.
and
And
reviewing.
and I'd say good GP practices have a really good team approach to this as well. So within their practice, but also with the palliative care CNSs and the palliative care community doctors that might be around in the area, talk to each other a lot, have regular meetings, and sort of say this is the discussion that we've already held. Sometimes it doesn't need all that much communication, but actually knowing that Dr. Sophie had that conversation about DNA CPR already, but the son from London wasn't involved in the consultation. Okay, now I know that, and I could potentially call the son from London, basically, who might take it very badly, according to Ethel, who I've just had that discussion with, basically. He's not going
Mm,
to take it very well. So, but could you have that discussion with him, you know?
mm. Yeah, yeah. And do you
The
think
son
there's any kind of
The man from London is a Brazilian expression, by the way. So I did a course in Boston on palliative care for a while, and I met a Brazilian palliative care clinician, and she said we've got this expression in Brazil called the son from London. So who's always phoning and always complaining and saying that he's not involved in discussions, and it's often because the family haven't involved him in those discussions and leave it to the healthcare professionals to pick up the pieces. I don't know if you get many sons from London, but that's a Brazilian expression.
yeah, I've heard the expression. Most of my patients are just Yorkshire based and not that many travelled families. Yeah, and I was just going to ask as well, do you think there's any kind of legal, ethical implications in different clinical settings that we need to be aware of and thinking about?
Yeah, I mean, it, ethical things. I mean, the religious aspect often is quite interesting, and we've had a few different situations. I'm working closely with Muslim doctors Cymru in Wales, who really sort of looking at going to mosques and other settings to explain what good advanced care planning can look like. So, for instance, when you're preparing for death, dying, then DNA CPR is one of the things that some religious community might think there's a sort of a fatwa to say that DNA CPRs are not allowed. Wrong. There's actually in Saudi Arabia a fatwa that says DNA CPRs are an acceptable form of medical practice, and those discussions should be had. But also things like if people want, after death arrangements such as, a quick burial within 24 hours, for instance. Sometimes if you get admitted to a hospital then on a Friday and as a bank holiday, it can take a long time for the registrar of births and deaths to issue a death certificate. And when people know that, that might change their mind in terms of wanting to, far more likely to want to stay at home and have their care there. So it's a really interesting one and a really tricky one to sort of organize. With regard to some of the legal aspects of it, I always find going back to the Mental Capacity Act and talking about how to involve people with diminished or fluctuating capacity can be difficult. You may have a really good DNA CPR conversation with someone who then has fluctuating capacity and then 2 weeks later may not remember that discussion. Still, you've got a DNA CPR form that you've written and you've written your communication with them. And then someone might come along and say, but they don't have capacity now, so that doesn't count. However, you've documented that they have said, no, I would not want CPR in my care. And that's a best interests decision, sort of saying in future, even, if I'm unable to communicate, I wouldn't want that in my care. So sticking to the MCA, the Mental Capacity Act, the Code of Practice, and all those things is a constant challenge, I think. It's tricky, but equally, you always bring it back to the patient and what the patient would have wanted. And for that, you sometimes often have to go back to the family members or the close ones or the partners or whoever and have to sort of say, look, this is a really tough question. I know it's difficult for you to answer this one. We would recommend this and this approach. However, if I had said that to Ethel or Roger or Albert, how would he have reacted to me? If he could speak to me right now and answer me, what would he have said in that situation? And that's good best interests investigating. My someone I communicate a lot with on Twitter, on email, is Mike Stone. You may have seen him. He's a sort of a carer who had a really bad situation with his own family members, and he now talks about MCA best interests decision making rather than best interests, because the term best interests is often used and abused in the wrong way. So best interests sometimes translates at what the medics think or the nurses think is the best interests, but of course it's really what the patient would have wanted in that scenario if they were able to speak. So MCA best interests is probably a better terminology, even if it sounds a little bit geeky.
Well, most medics are total geeks, really, aren't we, at heart? And do you think there's going to be any changes in the future to kind of DNA CPR decisions, to documentation, to the way we?
Yeah, I think. I mean, I was talking on BBC News at 6 and BBC News at 10 recently, in light of the situation that happened in Eastbourne in England, where someone had a DNA CPR form and they choked on their breakfast, and then the call handler didn't send out a first response ambulance immediately because of that DNA CPR form. And you kind of think, oh, it's situations like that can completely down a whole communication system in a sense if they are mishandled. So I think communication and education on these things has to be better. It's not about the pre-arrest period, it's about when someone's heart and breathing have already stopped. And of course, only pertaining to the condition that is written onto the DNA CPR form or the advanced care plan, such as advanced cancer or severe Alzheimer's disease with cardiac failure, etc., etc. Not when someone chokes on something where you should be giving first aid, and taking
something that you could
or anaphylaxis.
Yeah.
And that's where it gets difficult when if you have just one incident that happens across the UK. Of course, for the family and those involved, it's a complete disaster. It's a real catastrophe. But just that one incident, however good your communication and education and resources have been, you can have the perfect policy, you can have the perfect form, you have the perfect education system. It just takes one error from one practitioner or person to down the whole system. So I think DNA CPR is always at risk, if I'm honest. It's always at risk of willful misinterpretation as well. I think journalists can make good stories of it. It's always a scoop, isn't it? I like Michael Buchanan, who's the BBC reporter who's talked about it. He's quite measured in his approach, but not everyone is like him. Not everyone sort of approaches it in that way because everyone wants a sensational scoop, and that gets clicks these days. So I think DNA CPR and its processes are always going to be in some sort of danger. Same goes for advanced care planning. Same goes for the respect form that a lot of parts of England are using. All those things have the risk that they're all done with the right intentions, and the processes that scaffold them are often really well thought through, but it's the incompletely filled in DNA CPR forms, respect forms, and the incomplete communication that downs the whole system on occasion, and that can be the real problem. So the future, I hope, is brighter in terms of what we can try and do, and I'm heartened by the fact that we've got patient groups and we have bereaved families for Justice UK who are really interested in this topic and want to improve communication, don't want to get rid of it completely. That's heartening to me that is happening. But we face the battle of miscommunication, misunderstanding, misapprehension, and videos like this one today, I hope, Sophie, can do a little bit to address that if people are interested in listening to this.
Yeah, I guess the fact that if someone's still listening now, then they're interested in learning, and hopefully we'll kind of have better constructive conversations in the future.
Yeah, exactly.
Right. Is there anything else you wanted to add that we haven't discussed?
Plenty of things, probably, Sophie, but to be honest, we can do that in part 2 if you want.
All right. Well, thank you so much for taking time out to speak with me today. It's been really interesting, and I hope everyone finds it as interesting and useful as I have.
Thank you, Sophie, and thanks for giving me your time as well, and being allowed to talk about some of the aspects of DNA CPR and advanced care planning that we've had here in Wales and beyond as well. Thank you very much.
Great. Thanks, Mark.